Want to know what the most annoying sound in the entire world is? You guessed it, the ventilator alarm. Right up there with the IV pump and the CRRT alarm. Both of which we know what to do something about. But the knee-jerk reaction with the vent alarms is to holler for the RT, who may or may not be involved in something emergent somewhere else. So in this video, I want to teach you what the alarms mean, what warrants emergent and immediate attention, and what just maybe indicates suboptimal equipment use. Some can wait, some cannot wait. And in order to understand alarms, you have to understand a little bit of the basics about the modes of ventilation. In this video, I'm gonna take this very complex subject and break it down in a way that maybe you've never heard before, because my brain is a little bit backwards, so the way that I interpret things starts with the patient and works back. So that's kind of how I'm gonna present it. At the end, I'm gonna give you a step-by-step action plan that you can put into place as soon as that alarm starts screaming. If we haven't met yet, my name is Bree. I'm a nurse practitioner. I make content for nurses, NPs, and students. Welcome. I know you're thinking, why do I need to understand the vent when we have all these RTs? Well, the answer to that is that you don't always have an RT, right? They're not always immediately available to you, and your patient's ventilator alarm may warrant immediate attention. So you need to be able to ascertain what's emergent and what's not. That's the first thing. So we're going to go into that. Second thing is, you understand the interaction between the patient and the ventilator, you can more accurately diagnose asynchrony and properly sedate. And you can also get an interpretation of how sick your patient is just based on the mode that they're on, the compliance that you may see on the ventilator, the waveforms. All give you tons of information about what's actively happening with your patient. I'm going to include some links to my favorite resources down below that I highly advise you check out. You also need to get this book and you need to read it cover to cover. There's also a follow-up book to this one. That's the Advanced Ventilator book that you can get, easy to read, actionable. This one is for a deeper dive. All right, so let's get right into it. Let's do a basic dive into understanding modes. Okay, ventilators are just complicated. They are. You can do all the research in the world and have a very firm grasp on understanding the modes and what the ventilator can and can't do. And then as soon as you step foot in the room and start looking at these waveforms in your patient, like all that knowledge just goes right out the window. It's very hard to interpret what you're seeing. Part of what makes understanding the ventilator so tough for me is two factors. One, there are tons of manufacturers' events, and they all have these various proprietary terms that basically mean the same thing, but there's no universal language to say that this mode is equal to this mode on this ventilator. Like, why? It's so complicated. That is one thing. The second thing is that as we have gotten smarter as human beings, so have our ventilators. So most all of them offer this adaptive support technology where you're using dual modes. You're taking patient feedback to continuously change the target on the next delivered breath to the patient. So you never really know exactly where you're at. And that's kind of a hard concept to grasp. So to understand that, we need to take a step back and look at the basic components that go into ventilation strategy. I made a keynote presentation so you can follow along with this. So you may be going back and forth between my face and the presentation. So let's get right to it. In my mind, understanding mechanical ventilation boils down to understanding the interaction between what I control on the ventilator and what the patient controls in their brain. Their brain and their lungs are telling them to breathe a certain way, and I need to figure that out and deliver that to them on the ventilator. So to me, interpreting modes starts with understanding what they need. So the way that I break down the various modes is starting with what type of breath is delivered to the patient. So let's start there. All right, there are three basic ways that I can deliver breaths to a patient. And the first action is, I don't want to allow them to breathe at all. This is for the patient that's not putting forth any spontaneous effort of their own, who maybe has neuromuscular blockade, neuromuscular disease, TBI, CVA, some type of neuro impairment that's preventing them from breathing, some type of suppressed respiratory drive. When the patient tries to take their own breath, it's not going to allow it. And therefore it has a very high potential for asynchrony and is therefore mostly an obsolete mode of ventilation. I can't tell you in the last 20 years the last time I've seen someone on CMV. But this is how initially ventilators were designed. We turned all these knobs and we said, you don't breathe, we're doing it for you, and we sedated the heck out of them. The next mode is going to be pretty much everybody else. Anyone that we want to allow to take a spontaneous breath, whether they're taking a few breaths or a lot of breaths, some type of IMV or assist control that allows the patient to initiate and take their own breaths in between the breaths that the ventilator delivers. It's essentially for anyone that's in the ICU that needs ventilator support. There are lots of different varying dual modes that fall in this category. This is where the bulk of all of these confusing modes fall into. Essentially, I, as the controller of the knobs, dial in all of these different targets and volumes and pressures and things to deliver a breath to the patient at a certain rate. It also allows the patient in between those set breaths to take their own. And it can be either a fully supported breath in some type of assist control, or it can be completely on their own in an IMV like SIMV mode. Because these modes allow the patient's internal neural drive dictate their ability to take a breath and doesn't prohibit it, it's much more comfortable for the patient. The last mode is pressure support or CPAP. This is a mode that's designed for the patient who's doing all the breathing on their own. And the machine allows me to deliver them some type of support to augment their ability to pull in big volumes with decent pressures. Some people need very little pressure support. Some people need a ton of pressure support based on where they're at in their healing trajectory. This is designed for people who are improving, people that you want to do a trial on to see if they can come off of the ventilator, or the person who is improved but still needs continued ventilator support. So that's the first step. You're going to look at your patient and determine how much breathing are they doing on their own. None, a little bit, or all of it. And the vast majority of people are going to fall into that second category where they're doing some breathing. You want to allow them to do some breathing. And even for the patient who's not breathing at all, they're pretty much going to fall in that second category because, again, that first category is obsolete. You can give them pretty much full mechanical ventilation and allow spontaneous breaths in the middle without harm. So CMV, for the purpose of this lecture, are out. We're focusing on our IMVs and our assist controls. And these smart ventilators now have the dual capacity, things like pressure control volume guaranteed, pressure regulated volume controlled, uses feedback from the patients to continuously change these targets. But I'm not going to really go into that too much because for the purposes of this discussion, I mostly just want you to understand the two main components to delivering a breath and how they interact so that you can understand the alarms they generate. So first, let's talk about VCV, volume control ventilation, and pressure control ventilation. The thing you have to focus on is this. There are two variables to a breath. Well, there are actually a lot more, but again, for the purposes of this, there are two variables, pressure and volume. The amount of pressure required to get a patient to a certain volume of breath, or the amount of volume it takes to get a patient to a certain breath with a pressure limitation. Okay, the thing about it is you can only control one. Patient is going to respond with their own pressure or volume in response to what you gave them. So let's compare VCV and PCV. There are 5 components here that I'm going to contrast between these two modes. We're going to talk about the independent variable, which is the piece that I'm going to set. I stands for I'm the independent variable. I'm choosing to control this breath based on either volume or pressure. And the dependent variable is what the patient is going to give you in response to what you chose. And it's the inverse of what you chose. The pros of these modes, the cons of these modes, and the most common alarms that are associated with these modes. All right, let's talk about VCV first. In this mode, I am going to set the tidal volume that I want given to my patient. Therefore, the patient is going to respond with a certain amount of pressure, a peak and a plateau. These are two types of pressure that I'm going to see in response to the amount of volume that I'm giving them. The pros to this is that I can control tidal volume. I know that every time I walk by that room, they are guaranteed to get this much tidal volume and no more. And the reason we tend to default to this mode a lot in critical care is that the ARDSNet trial is really the foundation of what we do to treat people in ARDS. It's the only study that has shown that low tidal volume ventilation prevents further lung injury. It prevents villi. So the opening and closing of these alveoli and the shearing injury from it can be prevented by providing them these low tidal volumes. So in this mode, I know if I set it at a certain amount, 6 mils per kg, that's what they're going to get. And that's what ARDSNet kind of recommends. So we have a little bit of peace of mind about this. The cons to this are that you can have some asynchrony because there's a fixed flow pattern. And if the patient is sick, if they have stiff lungs, poor compliance, well, I've said, machine, I want you to give that person 6 mils per kg tidal volume. So therefore you deliver this much volume regardless of how much pressure it takes to get there. Well, if the patient is sick, The dependent variable that they're controlling is going to be their peak pressure. Their peak pressure is going to be through the roof because the machine's just squishing all this air into this really tight, hard space. And so therefore you can have high pressure, and this can lead to barotrauma. Therefore, the alarm that you're going to get is the high pressure alarm. Conversely, we have PCV, where the independent variable is pressure. That's what I'm going to determine. I'm going to have a pressure limited breath. I'm going to say, machine, deliver this much volume of air, but don't go above this set pressure. The pros of this are that we can control how much pressure the machine delivers. So typically we'll start someone out on VCV, their peak pressures will be high, and so therefore we'll switch them over to PCV. And this way, you're not going to have as much barotrauma. The other pro to this is that the second part of the ARDSNet study encouraged us to use open lung strategy, where we apply PEEP to keep the alveoli open so they're not opening and closing, slamming shut, causing further shearing injury. And in this mode, you can support that better. You also have better synchrony because the flow is variable. So typically patients are more comfortable in a PCV mode. Lastly, because you're controlling the PIPs, you're reducing your risk for barotrauma. Here are the cons though. If the patient's sick, if they have a high oxygen demand, if they're air hungry, if they're volume hungry, they're gonna have high tidal volumes. And because the volume is not set, the patient controls that piece of it. If they're sick and they're requiring big volumes, they will take big volumes. And therefore, you're not adhering to your low tidal volume ventilation strategy. The last piece of this is that based on where the patient's at in their trajectory, whether they're getting better or getting worse, their mechanics will dictate what their tidal volumes are, and therefore you have no guarantee of what the ventilation is doing. If they're sick, say they are in ARDS and they had high peaks, their peaks were 45, 50 in VCV, and you switch them over then, but they're still sick, well, you controlled your pressures, but the response is that they're gonna pull small volumes. So you can get acidosis in this mode. If they're getting better and the volumes are large and they have high demand, they can get alkalotic. The most concerning and common alarm in this mode is going to be your low tidal volume, low minute ventilation. So if you have a patient in ARDS, if you have a COVID patient and they're on PCV and you walk by the room and the minute ventilation reads 2 or 3, what's happening is that they're peaking out. Have y'all heard RTs use this term? Peaking out means that because I've set the peak pressure, I don't want you to go any higher than 40. They're getting teeny tiny volumes because they have sick lungs. They're gonna get acidotic and they're gonna code. This is a patient to be very, very afraid of. Okay, so let's move on to the alarms. First of all, the patient is disconnected or there's a leak. This is something you're gonna see on the vent. Patient disconnect or leak. This is bad. Okay, on the badness scale, it's around a 10. It's really bad. It means the ventilator's not working. It means they're not breathing, or if they are breathing, it's because of no support from the machine. This is bad. This is bad, friends. I don't think you need me to tell you that. This is an alarm that you need to run to. This is an alarm that you don't need to wait for your RT to finish their code for them to come check and see what the sound is. This is something you need to fix right away. The solution to this, hook them back up. Look through all your connectors, check all the plugs on the machine. Obviously, usually it's coming off here at the trach site. This is typical for a trach patient. Pop them back on. If you've done all that and this alarm is still going off, it's still saying that there's a leak probably, check that little balloon, that little pilot, you know, that little limb thing that comes off there that has the little balloons. Push it and see, is it flat? If it's flat, then the cuff is ruptured. Or listen to hear, are you hearing breaths in the trachea? You should not. That you gotta do something about too. Push some air back in it. You know, usually the RTs have a manometer sitting around somewhere. You can hook it up to it and see what the pressure is. This is something that you need to fix fairly quickly too, but a way that you can determine whether or not this is a true emergency or not is to look at your tidal volumes. Is your minute ventilation tidal volume in the toilets? Then yeah, you're not delivering ventilation to the patient. You can try popping them off and bagging them. Call your physician because they need to come and exchange the tube. Maybe the cuff is ruptured. This warrants immediate attention. Low tidal volume or low minute ventilation. Both of these are really high on the badness scale, 9, 10-ish, way up there with the disconnect and leak, because depending on how severe it is and how low your ventilation is, they're also not breathing. You should take them off and bag them until you can figure it out. Start troubleshooting by looking at, is your tube out? Has it just migrated? Is it completely out? Has it migrated up just enough that you couldn't tell outwardly? Check that cuff leak. Is there maybe just enough of a disconnect that you're not getting ventilation in, but not strong enough to trigger that disconnect or leak alarm? So run through all the things you would do to treat that one, checking all your connectors, checking your pilot. I guess, first of all, when you see this problem, you need to look at what the pressure's doing. If the pressure's low and the tidal volume is low, the tube's out, basically. If the pressure is normal and the tidal volume's low, you very likely could be in like a PCV mode where the pressure is set and the patient's getting sicker. And this is that dreaded patient that I was telling you about. So knowing your patient, knowing their diagnosis and why they're on the ventilator is key here. If you know they're in ARDS, I keep bringing that up because this is the most common thing that we see. You know, you have a septic shock patient who progresses to ARDS. This is something we treat commonly, especially in the medical ICU. Knowing that in advance, you know to look out for this alarm, and when you see this alarm, you should be nervous. First thing you're going to want to do is check your compliance. So I know on Draeger and Hamilton at least, the compliance is a number that can just be spit out to you. I mean, there is a calculation for it, but our smart vents have made this so much easier for us. You just change it to a certain view and determine what your compliance is. If you're down like 20, 30, 10, you have a very poorly compliant lung, and that's what's leading to this. Especially if you're on PCV, you need to be scared about this patient because they are likely acidotic, so you need to check an ABG. And if they're acidotic, you need to be concerned that they're gonna code. This is an alarm that's gonna warrant you finding immediate support to help you diagnose and treat. Then there's the apnea alarm, which you see all the time. Typically, this is in a patient that we're doing a breathing trial on. Is it something to be concerned about? Yes and no. I mean, as long as you know that this patient is in trial, these ventilators are going to deliver a backup rate. They are set so that if the patient doesn't take a breath for a certain number of seconds, it's going to deliver its own breath. And after a while, if nobody responds to this alarm, it's been silenced, because we're just trying to give them a couple more cycles or a couple more minutes to see if they're going to pick back up again, it's going to automatically revert back to the mode it was in previously. So yes, this is a concerning alarm, but I didn't put a badness scale on there because typically when you see it, the ventilator's got it. High PIPS, peak inspiratory pressure. This is high on the badness scale too. I give it like an 8 or 9. What does this mean? Well, it can mean a lot of different things. So the way that you fix this is by drilling down a little bit closer what the exact problem is with the pressure. There are two things that contribute to high pressures: your peak pressures and your plateau pressures. Peak pressure is the initial amount of pressure required to get a breath in, and on VCV modes where the peak pressure isn't set, it can be very high in a sick lung. It can be 50, 60, something super high like that. Plateau pressure is after that initial, I don't know, second or 10th of a second, whatever it takes to deliver that inspiratory flow. It peaks at a certain pressure and then it kind of settles out as the air distributes amongst all the alveoli. So on the waveform, I'm probably gonna do this backwards. You're gonna go up and then it's gonna kind of come down, dip just a little and level out. This is your plateau. Your plateau pressure is key. This is super important, y'all. So pay close attention to this. If your RT or your bedside nurse is telling you, my patient has high peaks, the first thing you ask them is, what are your plateaus? Because this helps you determine if it's a compliance problem or a resistance problem. And once you know that, you can further delineate into what actions need to be done. Have them do an inspiratory hold and tell you what the plateau pressure is. A lot of these vents do a continuous, like a very short segment automatic hold on it, like every third breath or something like that. And so it will continuously spit out a plateau pressure. Just ask your RT to tell you what the plateau pressure is. If your plateau is low, so in both of these scenarios, your peak's gonna be high. That's why you got the alarm. But if the plateau is low, you have a resistance issue. This is typically something external to the lung. You've got secretions in the tube, you've got a plug in the tube, you've got water in the tubing, the patient is biting the tube, or they have bronchospasm, COPD, asthma, lots of bronchospasm. So your treatment is going to be to fix all these things. So if you see this alarm, go in, suction. Can you pass the suction catheter? No, maybe you got a plug. Is there water in the tubing? Run your corrugated tubing and dump everything out. Look at the patient. Can you see them biting on the tube? If so, stop the biting in some way. Sedate them, put a bite block in there, something like that. If they're bronchospasming when you listen to their lungs and they're wheezing, give them a bronchodilator. Conversely, your peaks are high and your plateaus are high. This is a much more complicated, dreaded, and feared problem because it means we have a sick lung here, and lots. Basically, any lung process can lead to this. Things that are simple, like a right main stem, say your tube is migrated down, put your stethoscope on there and listen. Can you hear bilateral breath sounds? You can't hear them? Nope, pull back on the tube a little bit. Or get a chest x-ray. This will also help you to determine if they have a pneumothorax. Are they in ARDS? Because again, we talked about you're giving them so much volume, well, the pressures are gonna be high because it's requiring so much pressure to get to that. Regular old pneumonia can do it, filling processes like that. Pulmonary edema, atelectasis, then there's auto-PEEP. And I don't know if y'all know about auto-PEEP, but we set an extrinsic PEEP on the ventilator, which says that I want to keep the alveoli open at the end of expiration so that we don't have that opening and closing effect, that shearing problem. This is good. But if the patient has their own intrinsic PEEP because of something like COPD, this adds to the extrinsic PEEP. So you have intrinsic PEEP, which is your auto PEEP, and extrinsic PEEP. So then they have a ton of PEEP. And what is PEEP? PEEP is pressure. And what is pressure? It's increased volume within the intrathoracic cavity, which does what? Reduces venous return to the heart. And that's a little bit of a deeper discussion than what I intend for this video. So go out and do some research on auto PEEP. Here's what I do want to say though. And I say this with caution. If you go into a room of a patient who's coding and you look at the ventilator and the PEEP is at 24, something super high, turn it down. Their blood pressure is going to be in the toilet with that much intrathoracic pressure. So in a coding situation, turn the PEEP down. Outside of that, ask your RT or your physician to help you with this. This is not something you really want to be messing with a lot, but in a coding situation, turn it down. Another thing that can lead to high plateau pressures are obstructive sleep apnea, breath stacking. Oh my gosh, breath stacking, y'all. Nobody wants to see breath stacking on those waveforms because it's awful. So the patient will start by double triggering because they're air hungry. For whatever reason, they're not getting enough inhalation, their exhalation phase is too long, and or they just have a high demand. You're gonna see it on the waveforms on the vent. You're gonna see 2 breaths back to back. What that means is that you're getting double the tidal volume. And what is tidal volume? Tidal volume is lots of space in the intrathoracic cavity, and this can lead to codes. There's also an end-tidal not detected alarm. This is one that can really wait. This is not the one to go get your RT out of the code for. This is something is impeding the ventilator's ability to determine what the end-tidal CO2 is. This is not something that if you don't immediately fix, your patient's gonna code. The badness scale, like a 3 or 4. All right, yeah, I mean, it just means you have ineffective equipment. Does it mean that the machine has stopped ventilating for the patient? No, it doesn't. So this does not warrant you going and dragging your RT out of their code to immediately fix this problem. Let's talk for a brief minute about air hunger. This is the patient who's gonna look like they're sucking wind. They may have head bobbing, or some people call it tracheal tugs. Respiratory alternans, where the chest and the abdomen are going out in the inverse order. It's gonna look like asynchrony on the ventilator. The ventilator's probably gonna be alarming, those high peaks, high tidal volumes. It can lead to double triggering, which can lead to breath stacking, which can lead to codes. Because you have increased tidal volume, you have auto PEEP developing, you have reduced blood pressure, cardiac arrest. It's because the patient wants either faster flow or more volume. How do you fix it? Well, really the right answer is you need to go find your RT. My friend Levi would say the first rule of vent management is don't touch the ventilator, The whole reason I brought this subject up is because this is what you will see at the bedside, and this is what people want to do things about. This is the person that my bedside staff and my RTs are going to come to me and say, we need to sedate or we need to paralyze. Well, yes, that may be where we're headed, but that's not where we should start. We should start by trying to match the patient's need, their neural drive, with what we can dial up on those knobs. They're air hungry for a reason. Let's try and fix their air hunger problem rather than resorting to this heavy duty sedation or paralysis, because that just leads to further prolonged badness. Y'all don't need me to tell you that it's not good to keep a patient heavily sedated or paralyzed on a ventilator. All kinds of badness comes out of that. So if we can make them more comfortable by what we're delivering, that's what we should do first. Now, these things I'm going to tell you to do, I just want you all to have heard this and understand that there is another way than just pushing more Versed. First of all, take this patient and put them in a pressure support mode with a moderate amount of support. This is to assess what they're doing. If you put them in pressure support, remember pressure support is that mode where the patient's doing all the breathing on their own. Now, this is probably a sick patient, so I don't want to take away all the pressure. I want to give them some pressure, but I want to see what their neural drive is. How much do they need? So this is a diagnostic mode. So you're temporarily going to put them in a pressure support mode. Now you're going to watch what the breaths are doing on the flow waveform. What is their peak inspiratory flow? Do they need faster flow? Then you're going to go back to assist control and you're going to apply this flow rate. If this doesn't work, you're going to go back to pressure support. Now look at how much tidal volume do they generate on their own. Maybe they're volume hungry. Then you're going to go to a VC mode and apply this much volume. If neither of those things help, then you're going to have to sedate them, probably paralyze them too. But you got to fix the problem. You can't let it keep on going because it will lead to code, as we already talked about. If you've made it to this part of the video, kudos to you, because it's a heavy topic. It's a lot to pontificate on. It gets to be a little bit brain taxing, and I get it. But now, as your reward, you're going to get the best part of this video, which is the action plan that you're going to set forth when that alarm goes off. So what are we going to do exactly? 1, what is the alarm? Look at the ventilator. What alarm are you getting? 2, go straight to the specifics which we just discussed for those alarms. 3, if you're unsure what the alarm means or what mode you're in, here's what you do. Check all your connectors. Is everything hooked up? Dump the tube. So follow the corrugated tubing and dump all the water out. Suction. Can you pass that suction catheter? Listen for bilateral breath sounds. If not, maybe you have a pneumo, maybe you have a right mainstem intubation. Look at where the tube is. Look at the marking on the tube, and is it still in the centimeters of depth that it was when the tube was placed? Look at the patient. What is the pattern of breathing that they're doing? We didn't really talk about waveforms in this video other than a brief mention of it. Please know that you can interpret a ton of information from your waveforms. Your pressure, your flow waveforms tell you a lot of information. You don't have to really understand them to be able to look at them and see that things are irregular. Check your equipment. Did something come unplugged, like the end tidal connector? Is the cord unplugged? Is it saying something like check external power support? Is it running off of battery and needs to be plugged in? Is there an O2 connector problem? Looking through all of those things. During all this, and maybe even to start with, you're going to take the patient off the ventilator and bag, and you're going to call your RT. If you didn't figure out what it was, if it wasn't an easy fix, if the patient's getting sicker, you're probably going to be doing a chest x-ray and an ABG and calling your physician. The last thing on the list, and I put it last, is going to be more sedation, because that's what probably someone's going to tell you to do as number 1. I'm going to encourage you to put it all the way here at the bottom. The last option should be putting this patient down. We want them to be awake, interactive with the ventilator, and interactive with their environment so they can get better quicker. Please put sedation last on the list. That's all I got for you. I suspect that this is going to turn into a long video, and if you made it through all of it, I appreciate you hanging around. Obviously, ventilators matter a lot to me. I think that as critical care providers, this is a subject we should understand pretty well. The more you do it, the more you'll understand it, and as nurses, we're not really taught a lot about that ventilator. It's kind of shrouded in mystery. I encourage you to go in there and look at it. Have your RT talk to you about it and educate you about it. And when there's a problem, have them educate you about what the problem is and truly invest in your own education about it, because you really can make the difference in life and death in your patient if you understand what you're doing.